Imagine waking up to find that your own anatomy is just, well, slowly erasing itself. Like the skin is actually fusing together and burying itself.
Right. It sounds completely wild.
It really does. It sounds like a premise from some dark science fiction movie, you know? But for individuals living with this condition, called lichen sclerosus, it is a very terrifying, very physical reality. You're basically dealing with an environment that is actively destroying its own architectural landscape.
Yeah. And it's relentless.
Exactly. So welcome to today's deep dive. For this conversation, we've gathered this fascinating stack of sources to explore, honestly, a groundbreaking intersection between regenerative medicine and women's intimate health. We're investigating how a specific treatment known as the O-shot, which uses platelet-rich plasma, is quite literally changing the game for patients battling this condition.
And we're not just doing some broad surface level overview here either. We're really getting into the specific medical mechanics of it all.
Right into the weeds.
Yeah, exactly.
Yeah.
We're going to look closely at how a standard O-shot procedure has to be fundamentally altered, like right down to the exact millimeter of the needle placement when a provider encounters an active lichen sclerosus plaque,
Right.
especially when that plaque is located around super sensitive areas like the clitoral hood.
Yeah, and to guide this exploration for you, we've compiled clinical guidelines, detailed medical clinic protocols, and this actually includes direct insights from the original creator of the O-shot, Dr. Charles Runels.
Which is huge.
It is. Plus, we have extensive patient resources. So we invite you to just settle in with us. We are going to completely rethink how the human body heals itself using its own built-in blueprints.
I love that phrasing.
Thanks. But, before we get to the regeneration part, we really have to understand the destruction. So let's talk about that slow-moving glacier I mentioned. What exactly is lichen sclerosus doing to the body?
So lichen sclerosus, which is often abbreviated just as LS in the medical community.
Okay,
Right. It's a severe, chronic, inflammatory autoimmune skin condition. Basically, the immune system mistakenly targets the body's own healthy tissue, and this primarily presents in the genital and anal regions.
Okay, so what does that actually look like?
Well, visually, a provider will see these distinct, white, patchy, almost shiny or like crinkled areas of skin. But honestly, it's what's happening at a cellular level that causes the real devastation.
Right, the visible part is just the tip of the iceberg.
Exactly. The localized immune response is just so aggressive that it creates a massive amount of inflammation in those really delicate mucosal tissues.
And the patient experience that's detailed in these sources, it is incredibly distressing. We are not just talking about some mild irritation here.
No, about it all.
We're talking about severe, relentless itching that can disrupt your sleep entirely. There's burning, there's, micro tearing of the tissue from just normal daily movement.
Just walking can be agonizing.
Right. And for many women, it results in excruciating pain during sexual intercourse. It takes a massive psychological toll on top of everything else.
It really does. And beyond that sensory pain, it's the anatomical changes that are just so insidious over time. Because if it's left unchecked, that chronic inflammation triggers a scarring process that physically alters the entire architecture of the vulva.
Which is terrifying.
It is. The inner lips, the labia minora, can essentially shrink, erase, or completely fuse to the surrounding tissue. And crucially, it causes what is known medically as clitoral phimosis.
Okay, wait, I want to spend a second on that term.
Sure.
Clitoral phimosis, because it sounds very clinical and sort of detached, right?
Yeah.
But the physical reality of what that means for a patient is just profound.
It really is.
From the sources, it describes how the top of the clitoris actually adheres to the tissue around it. The clitoral hood just fuses shut, and the head of the clitoris becomes entirely buried beneath this thick, scarred skin. The original landscape is just completely paved over.
That's honestly the perfect way to visualize it. The inflammation acts like a glacier, just dragging scar tissue over the anatomy until it's buried and crushed.
Wow.
Yeah. And historically, the medical community's primary tool to fight this glacier has just been high-potency topical corticosteroids.
Which, logically, that makes a certain amount of sense, right? If lichen sclerosus is driven by an overactive immune system causing an inflammatory fire, steroids are basically the fire extinguisher.
Right.
They suppress that local immune response and calm the itching down.
They do. They suppress the immediate immune response very effectively, actually. But we have to look at how steroids actually achieve this and why they come with such a massive drawback.
Okay.
So steroids work by inhibiting the activity of various immune cells, right? But they also inhibit fibroblasts.
Okay, remind me what fibroblasts do again.
Fibroblasts are the specific cells in your body that are responsible for generating new collagen and maintaining the actual structural integrity of your skin.
Ah, I see. Okay, so you're putting out the fire, but you're also shutting down the construction crew that maintains the building.
Exactly. That's a great way to put it. When you use high-potency steroids long-term on incredibly delicate genital tissue, that inhibition of fibroblasts leads to skin thinning.
Which is called atrophy, right?
Yes, atrophy.
Hmm.
The tissue loses its elasticity and its thickness. So think about it. You have an autoimmune disease that is already damaging and scarring the skin. And your primary line of defense is a medication that fundamentally thins and weakens the skin over time.
That feels like a double-edged sword.
It really is. Furthermore, while steroids might stop the acute itching and burning, they do absolutely nothing to reverse the anatomical fusions that have already happened.
Right.
Steroids cannot unbury a clitoris. They cannot dissolve that glacial scar tissue and restore the original anatomy.
So you're just left with the structural damage, like the fire's out, but the house is still burnt and boarded up.
Precisely.
So this raises the big question, right? How do we actually rebuild a house that has been fundamentally altered or lost to this disease? Because we clearly have to move out of the realm of just managing the symptoms and get into the science of regenerating the landscape.
And this is where platelet-rich plasma, or PRP, enters the clinical picture.
Specifically, we're talking about a non-surgical procedure called the O-shot.
Right. Developed by Dr. Charles Ronels, the O-shot basically takes the biological concept of advanced wound healing and applies it directly to the compromised genital tissue.
Okay, but I was reading through the logistical protocols in our sources, and I have to admit, it sounds a little bit like a 19th century tonic at first glance.
A tonic? How so?
Well, the procedure takes maybe 10 minutes. You go into the clinic, they draw a small amount of blood from your arm.
Just like a standard cholesterol check.
Exactly. And they put it in a machine, spin it, and then inject your own blood right back into you. Like, how does taking blood from my arm and putting it somewhere else actually fix a fused clitoral hood?
It's a completely fair skepticism. A lot of people have that exact reaction. To understand how it works, we really have to look at what that machine, the FDA-approved centrifuge, is actually doing.
Okay, let's break that down.
So your whole blood is made up of a few different components. You've got red blood cells, white blood cells, plasma, and platelets. The centrifuge uses rapid spinning and G-force to separate those components based on their density.
So it's stratifying them.
Right. The heavy red blood cells sink to the bottom. But what the provider is trying to isolate is the golden liquid at the top, which is the plasma that is super concentrated with platelets.
Okay, so we've isolated the platelets, but I always thought platelets were just the things that clump together to stop you from bleeding when you get a cut, like biological corks.
For a long time, that was the primary medical understanding. We just thought of them as the plug. But Dr. Runels actually uses a very helpful analogy in the literature here.
Oh, what is it?
Think about when you scrape your knee. Your body forms a scab, right? And if you've ever looked closely at a healing scrape, before the hard scab fully forms, there is this crusty yellow material. Medically, that's called a fibrin matrix, but most of us just call it the yellow goo.
Right, the stuff you were explicitly told not to pick at when you were a kid.
Exactly. And the reason you shouldn't pick at it is because that yellow goo is not just a plug to stop bleeding. It is an incredibly active construction site.
Really?
Yeah, that fibrin matrix is packed with those platelets we just isolated in the centrifuge. And inside those platelets are microscopic structures called alpha granules.
Alpha granules, okay.
And those contain over 20 different highly active growth factors.
So what do these growth factors actually do once they're inside the tissue? Like, how are they helping the LS patient?
They act as chemical beacons. When the PRP is injected and the platelets are activated in the tissue, they essentially break open. It's a process called degranulation. And they release all of these growth factors into the surrounding area. These growth factors send out a powerful chemical signal, which is called chemotaxis.
Chemotaxis.
Right. That signal travels through the bloodstream, calling stem cells out of their dormant state in the bone marrow and directing them to migrate exactly to the site of the injection.
That is wild. It's literally blowing a biological whistle that tells the body's master repair cells exactly where to go.
It is. And once those stem cells arrive at the site, the growth factors direct them on what to become. They stimulate angiogenesis, which is the creation of brand new blood vessels to increase blood flow.
Wow.
Yeah, and they stimulate the fibroblasts, the very cells the steroids were shutting down to rapidly produce fresh, healthy collagen, and they even promote the regeneration of new nerve endings.
So the entire centrifuge process is basically just taking that exact yellow goo healing mechanism, extracting the architectural blueprint for healing, concentrating it down to its most potent possible form, and delivering it on demand.
Precisely. You are weaponizing the body's own repair sequence.
Which brings us to the real crux of the issue for this deep dive. Having a concentrated healing serum is an amazing scientific feat. But delivering it to the specific fused landscape of a lichen sclerosus patient is a totally different logistical nightmare.
It absolutely is.
So how does a provider actually alter the blueprint of the O-shot procedure to deal with an active plaque?
Well, it requires a fundamental shift in the standard protocol. To understand the alteration, you first need to know what a standard O-shot looks like.
Right, for a patient without LS.
Exactly.
Hmm.
When this procedure is performed for things like general sexual dysfunction, decreased sensation, or mild urinary incontinence, the provider injects the activated PRP into two very specific standard areas.
Okay, and where are they?
The clitoris itself and the O-spot, which is the space situated just between the urethra and the upper vaginal wall.
Okay, so it's a very targeted, established anatomical map.
Right. But when a patient presents with an active lichen sclerosus plaque, especially when we see that adhered or entirely buried clitoral hood we talked about earlier, that standard map has to be completely thrown out.
Why is that?
Because the standard sites aren't necessarily where the disease is doing the most architectural damage. The provider cannot just stick to the standard injection sites. The needle placement must be drastically altered.
So how do they customize the map for a patient with, say, a buried clitoral hood?
The protocol dictates that the provider actually prepares an additional quantity of activated PRP. And instead of just going into the standard O spot and clitoris, the provider must strategically place the needle just under the skin, directly into the dermis of the specific regions, demonstrating those lichenoid changes.
Directly into the plaque itself.
Yes, if the clitoral hood is fused to the glands, the needle is carefully directed into those exact fused margins. They are literally bathing the active, scarred plaques in a highly concentrated pool of these stem cell calling growth factors.
They are injecting directly into the active disease site. But, I have to pause here because the physical reality of that sounds absolutely excruciating.
Oh, yeah.
We just established that lichen sclerosus makes the tissue incredibly inflamed, hypersensitive, and prone to tearing just from friction. Putting a needle directly into a fused clitoral hood. How on earth is a patient tolerating that? How are they not jumping off the procedure table?
It is the single most common fear patients have when they're presented with this option. It's totally understandable. And it is exactly why the altered protocol includes an incredibly strict, highly specific numbing process.
Okay, good.
You aren't just rubbing some over-the-counter lidocaine cream on the area and hoping for the best.
I would hope not. That sounds like a nightmare.
No, the protocol requires a medical-grade topical anesthetic. It is a specially compounded cream containing 3 powerful numbing agents: benzocaine, lidocaine, and tetracaine.
Okay.
And the concentration is what really matters here. It is specifically formulated at a 20%, 8%, and 8% concentration.
2088. Wow, that's a massive localized block compared to anything you'd ever get at the pharmacy.
It is a profound nerve block. These agents work by physically blocking the sodium channels in the nerve endings, which basically prevents them from sending pain signals to the brain.
So how long does it take to work?
The provider applies a thick layer of this compounded cream to the clitoris, the labia, and the vaginal wall, and they allow it to sit for a full 15 to 20 minutes.
That seems like a while.
That time is absolutely critical because the cream needs to deeply penetrate through that thickened, inflamed tissue we talked about. And in some severe cases of fusion, the provider will actually follow up that topical cream with a tiny localized lidocaine injection just to be absolutely certain the deeper tissues are blocked.
So the goal is just to completely disconnect the pain receptors in that specific area.
Exactly. When that needle actually enters the scarred plaque to deliver the PRP, the patient should feel only a vague sense of physical pressure from the fluid entering the space, not sharp pain.
It's incredible that modern compounding can numb such damaged, hypersensitive tissue effectively enough to perform these deep tissue injections.
Science is amazing.
Truly. So let's look at the timeline here. We've drawn the blood. We've used the centrifuge to isolate the stem cell calling growth factors.
Yeah.
We've bypassed the standard injection sites. And instead, we've carefully bathed the specific fused lichen sclerosus plaques in this regenerative serum.
Right.
What actually happens in the tissue next? What is the outcome for the patient?
Well, this is where we really have to balance the genuinely remarkable clinical outcomes seen in the sources with the sobering medical reality of living with a chronic autoimmune disease.
Right. The sources certainly highlight some life-changing patient results. Women report that over the course of several weeks, the thin, white, paper-like tissue actually begins to remodel.
Yes, you can visually see the change.
It becomes thicker, pinker, and more resilient. The constant micro-tearing stops. The fibroblasts kick into gear, producing new collagen and restoring the tissue's natural elasticity. Patients experience improved natural lubrication and a massive reduction in the burning and pain during sex.
Which is life-altering.
Completely. And for many women, the results of this plaque-specific O-shot protocol can last anywhere from 12 to 18 months. And some patients even report going into a state of full symptom remission.
It's a profound relief for those patients. If you consider that glacier analogy again, the geothermal heat of the PRP has essentially melted the ice and allowed the landscape to regrow.
I love that.
But as with any medical intervention, we really have to ground this in reality. The O-shot is an incredibly powerful tool for reversing architectural damage, but it is not a definitive cure for lichen sclerosus.
Right, because the underlying autoimmune mechanism,
The immune system's confusion that causes it to attack the tissue in the first place.
it still exists in the patient's body.
Exactly. It's repairing the structural damage caused by the fire, but it's not turning off the arsonist that started it.
That makes perfect sense. And the clinical data is very clear that there is a documented non-responder phenomenon. Some women go through the entire altered protocol, get the shot directly into their plaques, and they just don't see that miraculous tissue regeneration.
Unfortunately, yes.
So why does it work like magic for one patient and do absolutely nothing for another?
That non-responder rate almost always comes down to the patient's individual biology and the local tissue environment. For the PRP to work, for those growth factors to successfully call the stem cells, and for those stem cells to successfully build new tissue, the local environment has to be structurally receptive.
So what factors play into that?
Age plays a role, as does overall metabolic health. But honestly, one of the most massive determining factors is the patient's hormone levels, specifically estrogen.
Ah, right. Because estrogen isn't just a reproductive hormone. It is the fundamental signaling molecule that tells vaginal tissue to stay plump, retain moisture, and maintain its thickness.
Exactly. Estrogen basically provides the structural scaffolding of the tissue. If a patient is postmenopausal or if they have severely low systemic estrogen for other medical reasons, their tissue might be entirely starved of basic hormonal support.
So what does that mean for the stem cells?
Well, if the tissue lacks that basic estrogen scaffolding, the stem cells called in by the PRP have nothing to attach to when they arrive. You can plant the most potent seeds in the world, but if the soil is completely barren and lacks basic nutrients, those seeds simply will not grow.
Wow. So for a patient to get the best possible results from this procedure, it's not just about showing up and getting the injection. It's about optimizing their entire hormonal landscape first.
It really requires a holistic, systems-level approach to the patient's health. And there is another critical medical reality check we must discuss regarding lichen sclerosus.
Okay, what's that?
Because it is a disease of chronic severe inflammation, it carries a small but very real, statistically significant increased risk of squamous cell carcinoma.
Which is a type of skin cancer.
Right, in the affected genital tissues.
Let's break down the why of that, because I think it's really important for you listening to understand why does an autoimmune disease lead to cancer?
It basically comes down to cellular turnover. When tissue is constantly inflamed and constantly being destroyed by the immune system, the body is forced to constantly produce new cells to try and repair the damage.
It's working overtime.
Exactly.
Well.
And every time a cell divides and replicates its DNA, there is a tiny chance of a transcription error, a mutation. When you force the tissue into a state of constant, rapid emergency replication for years on end due to chronic inflammation, the mathematical probability of one of those DNA errors turning into a cancerous mutation goes up significantly.
Which means even if the O-shot works perfectly, even if the stem cells rebuild the fused tissue, your pain is entirely gone, and you feel like you are 100% cured. You cannot just walk away from your medical team.
Absolutely not. The history of that chronic inflammation is written into the cellular memory of your tissue. Ongoing surveillance and regular biopsies by a specialist, usually a specialized gynecologist or a dermatologist, are absolutely mandatory.
So relieving the symptoms and reversing the structural damage does not remove the long-term cancer risk associated with the disease.
Correct.
That is a vital point for anyone navigating this. The O-shot doesn't replace your medical team. It is just an addition to your comprehensive care plan.
Exactly.
And speaking of additions, the clinical protocols note that for the absolute best outcomes, the O-shock isn't usually performed in a vacuum. It is increasingly being used as part of a combination therapy.
Yes, modern regenerative clinics are frequently layering these techniques to tackle the disease from multiple angles.
Like what?
Well, a provider might perform the altered O-shot to deliver the biological growth factors into the plaques, but they will often pair it with targeted vaginal laser therapies. Devices like DIVA or Morpheus AV use specific wavelengths of light or radio frequency energy to penetrate deep into the dermis.
And what does the thermal energy do?
It creates microinjuries that forcefully stimulate the fibroblasts to produce even more collagen.
So you are hitting the tissue with biological growth factors from the inside and thermal energy from the outside, basically forcing the tissue to wake up and rebuild itself.
Precisely. And in some cases, the provider will still strategically incorporate those low-dose topical steroids periodically. Not as the only treatment, but just as a maintenance tool to keep the underlying autoimmune inflammation suppressed while the PRP actively repairs the architectural damage.
Wow, it really is a complete paradigm shift in the treatment strategy. So let's just sort of look at the journey we've taken today. We started this deep dive looking at a devastating autoimmune disease that acts like a glacier, relentlessly burying and fusing some of the most sensitive anatomy a woman possesses.
Right.
And for decades, the only real answer the medical community offered was a steroid cream that temporarily put out the fire, but ultimately thinned the skin and left the patient with permanently altered, fused anatomy.
It was purely a symptom management strategy, not a healing strategy.
But by looking closer at the body's own biological mechanisms, by taking a simple blood draw, using a centrifuge to concentrate the exact same yellow goo growth factors that heal a scraped knee, and then fundamentally altering the needle placement to directly bathe those active scarred clitoral plaques in that serum. We are watching the paradigm shift in real time.
Really are.
We are moving away from just suppressing the symptoms of lichen sclerosus. We are now actively calling on the body's own stem cells to unbury the landscape and regenerate the anatomy.
Is such a profound realization. We're discovering that the most powerful tools we need to rebuild damaged fused tissue aren't always manufactured in a pharmaceutical lab.
No.
They're often already circulating right inside our own veins, just waiting to be concentrated and directed.
It really is incredible. It completely changes how you view your own body's capability to heal. And, it leaves you with one final incredibly fascinating question to ponder.
Indeed. Because if the highly targeted injection of our own concentrated blood can prompt stem cells to literally reverse the structural architectural scarring of an autoimmune disease as severe and relentless as lichen sclerosus, what other quote-unquote incurable structurally degenerative diseases in the human body are just waiting for us to figure out the exact right place to inject our own biological blueprints?
It makes you wonder what else that internal X-ray machine is going to reveal once we finally know exactly where to look.